We can go ahead with the next case presentation by Dr. Worawit from Thailand, and he is going to present about his techniques in slap lesions and paralabral cyst excision of the right shoulder. Dr. Worawit, can you share your screen? Yeah, thank you.
Can you see my screen?
Yes, we can.
Okay. Hello, everyone. Thank you for inviting me to this webinar. All around the shoulder instability repair. My name is Dr.Worawit. I'm Sport Medicine Department of Orthopedic, Bhumibol Adulyadej Hospital, Thailand. I would like to present case. This is 28 years old, right hand dominant, high level badminton player. Right shoulder pain that was going for about 1 year. His right shoulder continued to have the symptom and limit to overhead activity that were improved after rest. He then continued to have pain and felt instability. He is an active person and likes to go to gym. He has several episodes in last year. He has pain with bench pressing to the point, causing him to drop the weight down because he felt instability, underwent physical therapy, and eventually returned to play, but his right shoulder continues to have pain. No history of the shoulder dislocation. Medical history pretty insignificant. For physical exam, the spurring test negative on the right shoulder exam. You will see the atrophy of the infraspinatus muscle. He had full range of motion, weak infraspinatus muscle. 4 out of 5 stents of the external rotators, negative near and Hawking. He had a positive O'Brien test and dynamic label shear test. For the stability exam, sulcus sign negative, normal anterior and posterior loading chip test. He had a positive anterior apprehension and painful when performed jerk test, negative for MDI. The film X-ray of the right shoulder are unremarkable. So, what is the further investigation? I think we all agree we would like to advance imaging in this case. I'm going to put the poll out to you guys, so please answer that. Was advanced imaging? Was it your preferred advanced imaging in this case? Let me see what your opinion about the poll, what to do. CT, MRI, or MRI with arthrogram? MRI 65%, MRA 35%. Okay, so that's so important because the imaging will help the precision and of the treatment. For the result, there's still controversy about the MRI and the MRA, right? So for me, I would do the MRI with arthrogram because we will get a lot of additional information compared with the routine MRI, especially for detect the capsular level pathology. So if you get CT, I think unquestionably gives you a better view of the bone without question. So he went on to the conventional MRI that he already done in the other page before to see me. This is the T2 with facet coronal view. We can see the detachment of the superior labrum or slap lesion here. Supraspinatus looks pretty normal. And also you see well-defined cystic lesion adjacent to the spinal glenoid notch and can see the suprascapular nerve is located nearby the cystic lesion. This is the axial image showing the cyst adjacent to the spinal glenoid notch. There is a linear high signal underneath to the substance of the posterior labrum. The anterior labrum here does look pretty normal, fairly triangular shape. Subscapularis and infraspinatus muscle look pretty normal. This is the sagittal oblique view showing minimal fat infiltration and no muscle atrophy. From the MRI, we suspected the posterior-superior labral lesion here and the spinal gynoid cyst located at 11 o'clock of the gynoid, the diameter approximately 1.7 plus 0.9 centimeter. In this case, EMG and NCV were performed to evaluate for the nerve. The study showing subacute chronic axonal injury over right suprascapular nerve just below spinal gynoid notch. What is the suspicious diagnosis in this case? This patient has shoulder pain and particularly with the overhead activity. He then continued to have pain and felt instability, positive O'Brien test, and dynamic labral shear test, and also positive apprehension test and painful jerk test. The imaging showed the suspect that the posterior superior labral lesion and the paralabral cyst. So the provisional diagnosis in this case is probably slab lesion with paralabral cyst of right shoulder. What is about the surgical plan in this case? For this patient, he is very young age, only 28 years old, active and concurrent instability. I do the slab repair in this case and also have the cyst at the spinal gynoid notch. That's probably compression to the suprascapular nerve. I also do the decompression, the cyst, and do repair the posterior labrum. You can use either bead chair and lateral decubitors for the surgery. It depends on your experience or familiarity. Dr. Bancha, my mentor, published the supine position in the article of arthroscopy technique. In 2016, we found that a lot of advantage about this position. For me, I do the operation with semi-supine position. You will see the forward flexion 45 degree and abduction 30 degree. It's so simple way and easy to set up. You can use only skin traction. I will stand and traction with the normal saline bag. This position is friendly with the anesthesiologist to take care of the patient and easy to convert to an open procedure such as the lateral J. You don't need to depth and change the position. You can do in the same. You just drop down the arm. We do only 3 portals for everything we call triple instability. The posterolateral portal is just 1 centimeter from the corner, and anterior-superior and anterior-inferior portal. Both 2 portals should be stay far away to avoid portal jam. Intraoperative, I start with the posterolateral portal first, and then you will see the shoulder joint from this portal, followed by the anterior portal. This is the anterior superior portal. You will see the interval here. You can create the anterior inferior portal. That is the 3 portal. We can do stability get in one position, 3 portal. After you use the probe to identify the hidden lesion, that is the tone of the labrum from 9 to 11 o'clock involve the posterior bicep anchor. And then preparation of the labrum. Use the arthroscopic glass to reface the repair site deep to the cyst. You will see the yellow gelatinous fluid from the cyst here, that it comes from the cyst. Debitment the edge for fetch and for the good healing. It's time to suture. I prefer to put the stitch first before press the anchor. The anchor placement and the first suture passing from the posterolateral portal as fashion. One limb pass with the shuttle and then tie the notch and cut it. So the second one do like the same. This is the number 3. We working on the anterior superior portal and viewing from the posterolateral portal. We do it the same way and then tie the notch. The suture anchor will pass on 3 anchor. And now you see we have bump of the anchor. And then we check the stable repair of the labrum. Put off the first 2 weeks using and immediately put off pendulum and isometric exercise and passive range of motion, and then active range of motion and strengthening started at 3 months, return to contact sport in 6 months. For throwing athletes, provide time of it's about 9 months to return to play. And then for the follow-up, saw back at 5 months. At that time, he had full range of motion. Ended up getting the MRI to ensure that the cysts are resolved at 6 months, and he was able to return to badminton at 9 months. Just pre and post of MRI showing what it looked like for before and after seemed to be excellent healing of the posterior labrum and the cyst resolved. Infant spinatus then returned as normal as muscle mass back 2 years later. Good stand of the infant spinatus. A negative of the ovarian test. In no pain when do the test. A negative of the apprehension test. This can will give you a little bit of an idea, so this is one option for this patient. For take-home message, isolated slap lesion is rare, so you need to find the concomitant lesions at the lower cuff. Also, you need to know the variant of the normal anatomy, for example, sublabral foramen or buffoid complex. You can do either beach chair or lateral decubitus. It depends on your experience. Don't disturb the bicep tendon fiber. And also prepare for the bicep tenodesis in case of you cannot repair. One last message, posterolateral chair often present as a shoulder pain. Thank you.
Okay, thank you. It's a wonderful case to show the slap tear with the paralabral cyst, and it's the right indication of having the supraspinatus wasting tube. There are a few questions from the delegates. Do we have to do NCS EMG for all paralabral cysts?
I think if patient come from with the cyst, sometimes that no have the nerve symptom, I do not do the send to the nerve study or the case.
because sometimes we find it is AMG is going to be normal too. So basically, you go with your clinical findings and not responding to the conservative management. There's one more question. Intraoperatively, what would you do next if you do not see the cystic fluid being released as you probe the labrum?
Sorry, say again.
Because you don't see the gel in all the time when you do the decompression of your labrum. So what would you do in that case if you don't see the gel?
Or if we don't see, we just only decompress deflate the edge. That's so we have the systematic review that to compare about decompression or do not decompression. It's quite look like the same. We just only repair the posterior labrum because the theory that is the one-way valve. If you close the gap, that the seat will resolve, look like the same.
Okay. And
Worawit, I have a question for you. So when you're doing the procedure, sometimes the labral tear is very difficult to identify because it's a small labral tear. It's formed a cyst, which is like a valve, and then maybe that labrum has shut down. And when you try and probe the labrum, you don't find any tear. So in that situation, what do? Do you create a labral tear to go to the cyst, or do you go from the paralabral region to go to the cyst?
For me, it depends on the imaging. I told you that in the concealation or something like that, I will do the MRI with arthrogram to see the hidden lesion. Okay, so if in case of we cannot see the seed, I try to create the labrum and reattach the labrum back into the to normal.
Okay.
okay, maybe the one more last question. Because it's a young patient, you did the decompression, you did the repair of labrum to prevent the recurrence. What happens if the same case scenario, if the patient is an old patient, if it's a 45 years old or 50 years old, would you do a slap repair or just you do a decompression of the cyst?
I think if the patient is quite old, more than 50, so maybe I do just only decompression, or if he had a symptom and have the lesion of the bicep, I will do the tenotomy.
Okay. Thank you, Urva. I think we can move to the next talk.